behalf of today we are here on a very interesting topic about metformin in PCOS, why, when and how. As we all know that PCOS is one of the most common endocrinopathies among the women of reproductive age group and global prevalence is over 116 million. Prevalence in India of PCOS is again on the rise, which is almost around 3.7 to 22.5% only in adolescent girls. So, to share expert advice on PCOS, we have with us Dr. Manohar Motwani. As we all know, Dr. Manohar Motwani is a head of the Obstetrics and Gynecology Department at Rajawadi Hospital and also a senior consultant at Surya and Critical Care Hospital. So it's pleasure to welcome you, Dr. Manohar sir.
Yeah, good evening.
So, sir, in today's session about metformin in management of PCOS, why, when, and how, we would like to ask you certain questions which is very relevant for the clinical practice as well as for the general public. So, with all your experience, can you just explain each one of us that common abnormalities associated with PCOS and what are the risk factor about PCOS?
Yeah, PCOS is a very heterogeneous condition. Very difficult to explain, very difficult to understand, but very, very common. As you see, the incidence of PCOS keeping on growing. Abnormalities with PCOS which are associated are so very many that it affects the day-to-day living of all our patients. Amongst them are infertility, which becomes very common. So you have so many patients of PCOS having infertility. There's associated obesity is almost 70% of patients of PCOS are obese. That doesn't mean that there are no lean PCOS. There are definitely lean PCOS too. Obesity itself can cause a metabolic syndrome is an accompaniment of PCOS, perhaps the most dreaded worry we have in the future. Among the 40s and 50s, we have metabolic syndrome cropping up. Impaired carbohydrate metabolism, then we have diabetes mellitus type 2 coming up in these patients. Cardiovascular risks increase in cases of PCOS. There's always a risk of endometrial cancer, which is higher in PCOS. And one thing which tend to overlook most of the time, because the clinicians focus mainly on these parameters, we forget the depression and the CNS part of it. So depression is a very common accompaniment in adolescents also. So counseling may be of tremendous use in these patients. And because of the obesity, obstructive sleep apnea can be there in these patients. Now, coming to the risk factors, the funny thing about PCOS is that we really don't know what came first, whether the hen came first or whether the egg came first. Two basic accompaniments with PCOS are two factors. One is hyperandrogenism, and the other is insulin resistance. So all these factors ultimately work through these, which whether hyperinsulinism came first or androgen came first, we really don't know, because it was initially believed that it is hyperinsulinemia causing all the problems, but now it is perhaps more weight is being put on androgen levels. Obesity itself increases insulin resistance, causing hyperinsulinemia. That is one factor which can be responsible for these risk factors. Neuroendocrine. Now, this is a lot of study happening at the hypothalamic level, and they believe there's a persistent GNRS drive, unlike the normal patients having a pulsatile drive. So this is the one which causes persistent elevation of LH, and it goes on pumping down androgens from the ovary. So again, you have a hyperandrogenic environment. Genes play a tremendously important role here. And they have believed there are so many genes who are responsible, and the transmission of these genes, in fact, this intrauterine environment which plays a problem in these patients. And the fetus itself gets the entire programming to PCOS happens in utero, what we call the Pedersen's hypothesis, where the entire adult disease origins lies in the fetus. So these are and of course, not to forget lifestyle changes, which is really perhaps been one of those aggravating factors. And for PCOS, sedentary life, our dietary habits have really gone for a toss. So that is perhaps another reason which we have these things. Yeah.
Yeah, thank you very much, Dr. Manohar sir. Indeed, it was a wonderful explanation about the common abnormalities as well as risk factor. So in this, you have also detailed about the pathophysiology of the PCOS. So now for general public, if we want to
I can
understand
I
what
can
are
just
the...
add on a little to the pathophysiology. As I
Yes,
said
sir.
about insulin resistance and the androgen synthesis, the dysregulation of the androgen synthesis, and they perhaps believe it is because of the genomic problems which happen in utero. Now, it is believed that androgens are supplied to the fetus, and these fetus belong to these patients who are in utero. Most of the time are IGR at birth, but there is somehow this androgen being lipid forming hormone. There is visceral or adiposity happening in these babies, and they tend to put on weight. Now, this causes weight itself can cause insulin resistance. Insulin resistance causes a decrease in the SHBG. SHBG going down increases the androgen levels. On the other hand, your neuroendocrine system causes this thing GnRH drive, the LH increases androgen, so the androgen goes into a dysregulated state. This androgenic environment in the ovary affects ovulation. So this is how it's a play. And what happens? This androgen itself causes hyperinsulinemia. So a vicious cycle is created. So we really don't know where it all starts, whether it is insulin resistance or it is hyperandrogenism. Yeah.
Yeah, thank you very much, sir. So, sir, we come to our next question about like what are the common signs and symptoms about PCOS. So, like at initial stage or patient it at the like later stage, and so to understand and to have a consultation with the endocrinologist or obstetricians or gynecologist or diabetologist. So, what are the common signs and symptoms what we need to focus and we need to create an awareness among the common public?
Yeah, see, as more and more evidence is coming in, we know that the PCO starts in utero, but the manifestation can happen at any age. You may have a teenage who comes with the same symptomatology as a PCO patient. You may have a young girl in her 20s who may manifest PCO a little later age, or you may have a lady later in life manifesting PCO. So exact trigger, we really don't know when it can come. But one thing you have to remember, there's all these symptomatology which comes are related to the abnormalities in the metabolism. Like you have hyperandrogenism, hyperinsulinemia. So these patients come to us with symptoms of menstrual irregularities. Now the commonest misconception here is that it is only a longer cycle, which is one of the symptoms which give you a feeling she's got PCOS or PCOS. But remember, it's an ovulatory dysfunction. A shorter cycle also can be one of those markers of PCOS. Not only that, you've got PCOS with normal cycles also. So
Yes,
menstrual
sir.
irregularities is one particular symptom which is there in these patients. They may come to you with that. And remember, one point which I want to tell people is please don't diagnose PCO before the age of 18 in these young girls. And the strong tendency of papers coming to us who tell us that sonography showing evidence of PCOS. Please don't diagnose. Label them at risk of development of PCO, but do not label these patients PCOS before the age of 18. The next symptom they have is acne, which they say has been appearing, oily skin, then appearance of hirsutism, the upper lip hair, chin hair, on the chest and all. Then we start grading these particular things in these patients. The examination findings, obesity is more common, BMI is on the higher side, BMI more than 25 is taken as overweight. And you may have evidence of hyperinsulinemia or insulin resistance like acanthosis nigricans. Once you have that, you know this is a case of insulin resistance in these patients. So all the symptoms and signs come are gone because of insulin resistance and hyperandrogenism. And
Yeah.
of course, diagnosis. Now, when you come to diagnosis of PCOS, any two of the three should be present. Now, ovulatory dysfunction is one, hyperandrogenemia is the second one, and PCOM, what you call the morphology, PCOM morphology. Now, remember, there is a very close differentiation between a multicystic ovary and a polycystic ovary. And our ultrasound friends have got a great tendency to write on the paper that PCOS cannot be ruled out, use this thing, clinical correlation. So, there has to be a differentiation in terms of multicystic ovary appearance and PCOM. If at all you get clinical hyperandrogenism, there is no need to proceed for any biochemical investigation. So, if you have got an ovulatory dysfunction in a patient and hyperandrogenism, something clinically in them without a PCO ovary, you call it this thing. Accordingly, you have various phenotypes. You know, all the three will form one phenotype. The ovulatory dysfunction plus hyperandrogenemia will fall the second phenotype. Hyperandrogenemia plus PCOM will be the third phenotype, and or irregular cycles along with PCOM may be the fourth. So you may have a patient non-hirsutic PCOS. You may have a patient who's got a normal menses PCOS.
Yeah. Very well said by Dr. Manohar sir, like how to diagnose the PCOS and what are the common signs and symptoms. So, sir, regarding the common signs and symptoms, there are several signs and symptoms which mimic the clinical features of other disease. So, can you just
Yeah.
explain us what are the disorders that mimic the clinical feature of PCOS?
Yeah, this is what we call secondary PCOS. That differentiation becomes very important because sometimes we are so much to overdiagnose or we go on saying this is PCOS. The moment a girl or a lady walks into your clinic, you look at her and say looks like PCOS. Well, sometimes you
Yes.
in fact jump the gun. So it will rather we rule out certain other what we call the mimics or the duplicates of PCOS, what we call secondary PCOS. One of them is hypothyroidism, which may mimic in terms of obesity and irregular cycles in these patients. The second is hyperprolactinemia, which can also give rise to irregular cycles and infertility, and the same scenario. And third, perhaps which is the closest to mimic, is non-classic congenital adrenal hyperplasia with a 17 alpha hydroxylase deficiency. This is where your estimation of your because here the source of androgens is not the ovary. The source of androgens here is the adrenal gland. So estimation of DHEAS becomes an androstenedione becomes more important. When you're suspecting it, rule them out because before you label a classic PCOS, rule out these three conditions at least by doing a good thyroid function test, a serum prolactin on an empty stomach, and your 17 hydra alpha this thing hydroxylase this thing estimation. So that is called
Uh,
secondary PCOS.
Thank you very much, sir. On the you have clearly highlighted those conditions which mimic the clinical features of PCOS, and directly we should not jump to the conclusion that patient is a PCOS patient. We need to do a proper investigation about it. So, sir,
Correct.
regarding the therapeutic options of PCOS, so what are the various therapeutic options available in current scenario and in the management of PCOS?
Yeah, as we all know, the etiology of PCOS is really not known. It is all a mix up of many factors. So when we try to do that, we try to correct the symptoms, we correct the underlying abnormality. Like our attempt is to correct the hyperinsulinemia, our attempt is to decrease the androgen level. So all of it is directed to but once you reduce the hyperinsulinemia and or also reduce the androgen levels, you get your results. How do you go about it? Now, the first and primary thing which is seen in these PCOs is insulin resistance. In about 70% of cases, I've got insulin resistance. Again, I repeat, lean PCOs also have got insulin resistance. They've got a visceral adiposity. So, with good ultrasound, you may find a lot of omental fat in these patients. So, these patients also fall into the category of PCOS. So, lean PCOS categories, no, they are more difficult to treat. We start with the diet. Our main idea is to bring down the BMI to less than 25. Maybe very difficult, very, very difficult. Perhaps an advice which is very easily given but very difficult to handle. So here we require the need of a good dietitian, a dietitian who can help us out by formulating a customized diet. Like a general diet, you're eating and all can come to you. When it comes to infertility, all the experts believe that even if you reduce weight by 5% of the existing body weight, you may get some results of the treatment. Slow and steady is the key. Exercise plays a very important role. You can do core exercises, you can do weight training. Again, it comes under the effect of these lifestyle modifications, your food habits, your exercise becomes a very important role. Counseling of these patients, because so much of Google is around the place. Anybody who reads the sonography report and comes to you, the girl is well informed about Google. Now, it goes to say that perhaps it is the end of the world for that particular girl. PCO ho gaya, matlab it is the end of the entire thing and she's going to get diabetes, she's going to get cancer in life. Well, control. PCO can never be eradicated. PCO should be kept in check. And once you keep in check, you almost lead a normal lifestyle. So counseling of these patients regarding the condition, explain to them that this is the condition which has to be controlled. It's like a horse which has to be kept in check. Third thing is pharmacology, perhaps which is the most used among people. But as I say, importance has to be given to diet, lifestyle changes, and counseling. Followed by that comes the pharmacology. Now, here comes the use of drugs where we use hormones like oral contraceptive combined pills, estrogen, progesterone combinations. We make use of anti-androgens for the treatment of hirsutism. We make use of insulin sensitizers, which perhaps is becoming the mainstay in the therapy of PCOS. So pharmacological management will be directed towards the need of the patient. If the patient has got something, accordingly we take what should be given to these patients. Yeah.
Yeah, thank you, sir. Very rightly said, there are various therapeutic options in the management of PCOS. So, sir, again, one more question, which is continuation of previous question only. Sir, do you believe that hyperinsulinemia can lead to a delay in ovulation?
Of course, as I said, hyperinsulinemia happens why? Let's look at the basic problem now. You got insulin resistance. You have a patient with obesity, and you've got even androgen itself can cause insulin. I told you it's a cycle between the play between androgen and insulin. If there is a peripheral insulin resistance, your pancreas is made to secrete more of insulin. So you get into a state of hyperinsulinemia. Now, this particular hyperinsulinemia changes or decreases it in fact brings about increased sensitivity of the to the increase to of the ovaries to LH. Now, this LH has got a very funny way of acting. It causes a premature differentiation of these cells. So that's how it affects ovulation. So an intra-ovarian androgenic environment is the one responsible for anovulation. So when we try to correct these patients, we try to decrease the intra-ovarian androgen environment by giving them insulin sensitizer. So we bring down the insulin level, at the same time add an anti-androgen to these patients. And that's how the ovulation can be restored in most of them. Most of them. So it does
Thank you
affect
very much.
ovulation. Yes.
Yes. So, sir, as you all know, the metformin, it is a very old molecule, and it's have done wonders in the management of diabetes. So, how do you perceive what is the role of metformin in PCOS and mechanism of action of metformin in the management of PCOS?
Metformin today is the wonder drug, if you really ask me. More and more reports are coming in of metformin. And when we start giving a patient metformin, मेरे को तो diabetes नहीं है. ये तो मेरी नानी दादी ले रही है, तो मैं क्यों लूं? So you have to tell the patient that this is the drug which perhaps spells magic. Now, what does it really do? As he said, insulin sensitizer. So what it does, it makes your peripheral tissues more responsive to insulin. So once you have the peripheral tissue responsive to insulin, the insulin acts much better. So now the feedback goes to the pancreas. Now you've had enough of your play. Now let's bring down the insulin level. So it brings down the insulin level. The insulin level brings down the LH levels. And this LH level brings down the androgen levels. And that's how we get your effect on the ovary. And once the effect on the ovary comes up, ovulation creeps in and the cycles become regular in these patients. So we get a great advantage. The next question is, what about the role of insulin overall? Now we know that PCOS is not only an ovarian condition. PCOS is a metabolic condition. So if you look at the role of metformin or your metformin in these cases, it affects the hepatic, it decreases the neoglucogenesis. It increases the peripheral uptake also of glucose. And it has got a definite action of cardiometabolic protection. Now they say there are some papers which say it is very protective, but I think by and large uh, most of the data which comes up say that it has a potential cardioprotective or a cardiometabolic corrective effect. Now, the next question is weight gain. People think about metformin will give for weight loss. Now, it really doesn't work so much against weight loss. It may make the patient feel that, well, my drug is working, give you a positive attitude of weight loss. At the most, it may bring about a very marginal weight loss, but glycomet is not the drug to cause any weight loss in these patients. Cardioprotective, yes. Metabolic protection is there. It helps in decreasing the dyslipidemia or the lipid levels in these patients. And perhaps the most important thing is that it may have a potential role in lowering the risk of endometrial cancer. So it does play a very important role for overall. So you look at it, it's a molecule which covers almost everything of PCOS.
Yeah. Thank you very much, sir. Very well. You have explained about the role of metformin in PCOS and mechanism of action of metformin. So again, sir, in detail, little bit, we would like to understand about the ovulation induction and role of metformin in ovulation induction. So can you just elaborate on this particular pointer and why metformin or clomiphene citrate would be a first line of agent in the ovulation induction?
Well, we are, as already said, insulin sensitization, bringing down the insulin resistance is perhaps the mechanism in which all of them have to work. Now, when it comes to ovulation induction with metformin, it is believed that we can, it once it reduces your LH levels, the intra-ovarian androgen environment improves and the ovulation happens in these patients. So it is a drug which can be used for patients to induce ovulation. The question next came is that whether metformin alone should be used or is it clomiphene, because everywhere it has been given clomiphene is the first drug of choice. Now, there was a study which was conducted of metformin alone with clomiphene cited alone for induction of ovulation in non-obese patients. And they found that they have got an equal effect, equal ovulation rate and an equal take-home baby rate. It's live birth rate. So they said, well, either of the two can be used. Then they went a step further to see what really can work wonders. So it came to the conclusion, well, if you find that if you're using for more than 6 cycles, then metformin perhaps takes the cake of a better outcome when compared to clomiphene alone. But I'm a person who perhaps gets the best of both worlds. When it comes to a controversy or a choice between two, which are usually not having any great side effects, I combine the two. So for me, it is the best of both worlds. When it comes to my patients, I tell them if you have good diabetes, put them on glycomet or on your metformin for the first few couple of months or 2 to 3 months, sensitize the entire system, and then plunge it with an oral ovulation in these patients. So I do about 2 or 3 months of priming of the patient with metformin. So I combine the two.
Yeah. Thank you very much, sir. Sir, there's one question from the audience that max dose of metformin in diabetic patient and in obese patient. So, what would be the maximum dose can be given in
See, the
diabetic patient?
standardized dose is usually 500 milligrams 3 times a day. Maximum we can go up to 2 grams a day, or we have got a slow release preparations of 850 milligram twice a day. Beyond that, it doesn't work. And the funny part about metformin is that there's this side effect kind of a thing creeping up in patients in the non-compliance. So there is a way on which perhaps say we start with 500 milligrams once a week, and then we make it next week twice a week and thrice a week. But I did have a talk with some of the endocrinologist friends, and I told them, how do I get over? He says it is not dose dependent. It is not. One tablet may give you nausea, vomiting, and metallic taste. Even one tablet can need not be 3 tablets. So otherwise, 10% of patients do have a little non-compliance with metformin. But that is a wonderful drug. But normally we don't exceed 1500, at the most 2000 milligrams.
So, sir, again, in PCOS patient, like after the treatment, appropriate treatment, and they get pregnant. So, do you believe that metformin should be continued or it should be stopped with immediate basis when patient get pregnant?
Well, there are a lot of papers about the potential harm of metformin, but by and large, when I had a talk even with a lot of diabetologists to look after pregnancy and diabetes, what we really do is we advise the patient to continue metformin. There's very little data to say about teratogenicity of metformin. But we continue up to 12 to 13 weeks and we stop the metformin at 12, 13 weeks because that's where our need is up to the first 3 months. Because they believe there may be high risk of spontaneous miscarriages in patients of PCOS. And we give metformin for the first 12 to 13 weeks. After that, I discontinue.
And sir, regarding this management, there are certain non-pharmacological products are also available in market. So, what is your opinion with
My
respect to it?
experience is very little. If you really ask me, very little. There's so much of anti-obesity drugs which are given clofibrate and this and that. I really have no idea. I think a good, well-designed diet by a good dietitian can do wonders. I've got a wonderful dietitian with me. Believe me, I've seen results. And the patients are, you can almost have the same food which you normally eat, just modify it a little, and you have a customized diet. There's no question of starving here. So we don't have to go to those powders which we take once a day and skip a meal and all that. Well, there are many companies who make those. Don't
Yes.
eat your dinner, have your powder. But I, for one, normally doesn't believe in it because I think a good diet, give her all what she can eat. You don't have to compromise on vitamins and minerals in these patients.
Thank you very much, sir. And sir, one more question I would just like to ask you. In your routine clinical practice, which is the age category which is having a most common PCOS prevalence, like in your routine
My
OPD?
most of my patients now, what has happened is there's a changing trends of these young adolescents coming with the risk of PCO. I've got
Yeah.
girls about 14 and 15 having significant acne, obesity, and irregular periods. But as I told you, the ovarian axis, the hypothalamic pituitary ovarian axis takes time to get a little matured. So we normally don't give, we just mark them and keep them. We follow the same protocols of management, mind you. We tell them weight loss, we make them counsel them, they're at a risk of PCO. You can have a PCO later in life. So I think it's about 30-40% are as adolescent, the others are in there. If they come for infertility by and large. So if you take about 30% adolescents and about 70% the other one, that's what my practice shows. Every person may have a different percentage.
Yeah, and sir, in last 2 years, due to this pandemic, so like in COVID scenario, so there is lot of things have been changed. Lifestyle change, or maybe there is suddenly increase in weight, and lot of patients are not going to the school or workout, or maybe at the office. So sedentary lifestyle is going gaining nowadays. So what is your opinion? Do you believe that prevalence of PCOS have been increased in this pandemic?
Still, I think the data is not out on it. At least initially it was there when the COVID was there, not very many patients attended doctors, and doctors didn't see very many patients. I, for one, used to be very scared of seeing a non-elective patients and never used to call them to check up. So these are all non-elective patients. But if you totally look at the logistics, probably weight gain, this all the effect will be seen now. I think as time passes, when more and more patients start attending doctors, perhaps this will be the time for us to tell after 2 years of COVID what is the scenario. But there may be a theoretical possibility of PCO increasing. Because we have been seeing over the years menarche getting shorter at 8, 9 years, and menopause coming at 35, 37, and 40. So things are going wrong. So lifestyle modifications, your environment, more importantly, environment. Who knows what sort of a non-veg are you eating? What sort of drugs are being pushed into those things? So now a new trend is diet. You need not have in burgers, but the food which makes the burger itself may have something which may give rise to some changes in the system. These are all triggers for PCOS. See, why doesn't everybody manifest PCOS at 17, 18, 19? The triggers change. The trigger gives it that you are sensitive to PCOS. The day you get your trigger, you manifest PCOS.
Great, sir. Very wonderfully, you have explained everything. What are the scenario changing, and again, your dietary habit and your sedentary lifestyle, everything matters in the management as well as developing the symptoms of PCOS. So again, sir, there are various international evidence-based guidelines. So what is your opinion about the assessment and management of PCOS in based on this international evidence and based guidelines?
Yeah, these guidelines have come in 2018. They have really been marvelous. In fact, everything is happening so quickly. This is one topic which is changing perhaps every day. That's how quick it changes. Now, remember one very important thing. If you see a patient with menstrual irregularity and clinical features of hypoandrogenism, just take and label her as a PCOS. Very simple, PCOS. There is no need, again I repeat, any two of the three, there is no need for a sonography in this patient. If at all you are doing a sonography to phenotype her, whether she's A, B, and C, all three together, then this particular sonography has to be done on day 7, day 8, and not in mid-cycle or pre-menstrual, because your ovary has to show its normal volume before the follicles start growing. You may have an erroneous volume in the other half of the cycle. So we do not do any biochemical test when there is clinical hyperandrogenism. Remember that. Once you have hirsutism or acne, you know this is hyperandrogenism. Do not going for any fancy androgen levels, testosterone levels, and androgen indexes. Only when you're suspecting a biochemical hyperandrogenism, then you may be able to do a androgen index, because free testosterone is not being done. It is not a standardized level. Now, coming to the management, as we said, the mainstay of management only two drugs here, depending upon the need of the patient. One is the insulin sensitizers, the other is a combined oral contraceptive pill. Now, when we are using the oral contraceptive pill, along with the lifestyle changes, along with the changes in that patient's weight and the lifestyle, and if it doesn't work in spite of all that, then we have a right to add metformin to these patients. So, OCs, along, if there is no improvement in the lifestyle in these patients, the overall weight loss charts and all that, then you can add metformin in these patients. This is the reason. So it gives us more leeway to start metformin. Similarly, in adolescent girls, if the BMI is more than 25, your weight loss is not working, and she's on OCs for her hirsutism and severe acne is a social stigma. They don't want to go out with those pimples.
Yes.
So you give them for about few months and then you can add glycomet in these patients or metformin. I'm sorry I'm using the word because I'm more used to it. And when it comes to the other part of the thing, suppose we can start lifestyle changes not happening, not bringing down the metabolic control, then these patients can be put on metformin. Similarly, lifestyle changes not working with the metabolic control, with the BMI more than 25, please add metformin. So metformin can be used liberally. It's a great drug to use, and I think people have taken metformin for years and even lifelong. There are studies abroad where the girls with PCOS are taking metformin lifelong.
Yes, sir.
It does have a great metabolic protective effect. If not ameliorating your metabolic syndrome, it will at least bring down the severity and also give you a less risk of endometrial CA.
Very wonderfully explained by Dr. Manohar sir. Sir, one question I got from the audience. Again, it was purely based on this continuation of previous one. That how long treatment of PCOS should be continued?
Very tricky question. Very, very tricky question because this is what the girls really ask you. See, I, for one, use oral contraceptive pills very liberally. Now, the question which all of you must be having is to use the anti-androgen progesterone along with ethyl estradiol and or vis-a-vis a regular, beautiful combined oral contraceptive pill of ethyl estradiol and the other progesterone. Believe me, both the pills work as effectively. In fact, they are saying the pills with cyproterone acetate have got more side effects as compared to the normal ethyl estradiol and the normal progesterone, the 19-not testosterone derivative. So use either of them. Now, when a patient or a girl comes to me with hirsutism and this thing, I start them or for that matter, irregular menses. So first I put them on progesterone, just progesterone, whether they have no hirsutism and all that. And the person, they at least the cycles get regular. And then give a break for a few months. Again, correct them. Again, it's just a jump session. Few months on, few months, because we don't know the cumulative. They say progesterone can be given for 5 years for endometriosis, but more so with oral contraceptive pills. Once the patient feels symptomatically better over a year, a hirsutism or acne spills out, I give them a couple of months washout period. Now, this is my personal. I don't know whether it works or not, but it is for my peace of mind that I give them a break of 2 to 3 months, or I may swap them over to progesterone for 6, 7 cycles because the hirsutism hasn't come back. And if it comes back again, swap them. It's a play, It's nothing is given in the books, nothing is given in the literature. It's the way you work, but you have to follow up these patients with every few 6 monthly or one yearly LFTs in these patients to know whether your OCs are not having. But OCs can be used up to 5 years without a problem. And once she reaches the childbearing age, your entire focus changes to ovulation, induction, and delivery. But they have to be on the watch. As I said, 50% of these patients are going to have diabetes by the time they touch 40.
Yes, sir.
So lifestyle modification is a continuous process till she's alive. There is nothing like ideal body weight. Maintain your ideal body weight till you're alive. No
Yeah.
escape.
Yeah. Thank you very much, sir. Very wonderfully, you have explained all the questions about the management of PCOS. So, but one last question from my side: what is your opinion about inositols? Because there are several studies they are
Well,
coming up.
lot of things. It's really raising its head. It's really raising its head. Believe me, it's really raising its head. And there is a significant role, especially in this combination of 40s to 1 of Mayo versus Cairo, D Cairo. And they are seeing really good results. So now we have something which can say that it is not only metformin is going to rule the future. We got something coming up like a new kid on the block, but a lot of papers. Initially, 2 years back, we didn't have much data, but now more and more of data, especially so in patients who don't tolerate metformin, because there is a significant 10-15% of people who says, God, doctor, give me anything, but don't give me that drug. My eating is gone. I can't. I just have puking feeling the whole day. It's a great thing. Obese patients, you have a 40s to 1 combination. And I think it's time that we give metformin a second thought. And it has showed great results even with infertility patients when you put them on this use of combination. For lean PCOS, they say plain myo-inositol works very well. But for obese PCOS, they say that the D-Cairo-Mayo combination works better. But in case you have a lean PCOS, then plain myo-inositol of 2 grams per day works very well. The treatment says 3 to 6 months, but it can be taken much longer than that. Once she gets pregnant, then you can stop your things as time passes.
Very well said about the inositols also. It is new data which is coming up, and again there are certain combination in India which is coming up with a higher dose of
Yeah, yeah,
T-Cairo
yeah,
and
yeah.
myo-inositol
And there
combination
many
as
of them
well.
are combining the best of both worlds, giving you metformin plus
Yes,
myoinositols.
yes. Sir, one more question regarding the drug adherence in the management of PCS. So, how much percentage of patient usually are compliant to long-term management of PCOS in your routine clinical practice?
If you really put them that this is how counsel the patient pretty well, they can be continuing. There are no side effects. They know their lifestyle has improved. Everything is falling in place. Let's look at the cosmetic part of it, the metabolic part of it. Everything is nice and lovely. What is the problem? As long as they happen to be in touch with you, you have to emphasize that this is the way I can control your PCS. I'm not going to get rid of it, but I'm going to control it. And once the patient gets this feel, I'm sure they will never leave you. They'll never be non-compliant.
So again, from all this discussion, we get to that psychological counseling of the patient is also very
Very
critical
important. Most
because
neglected.
psychology, yes, most neglected. And how to create an awareness about the psychological counseling in the management of PCOS, because again, that is a certain aspect which we in India, especially in India, we need to focus about.
And don't Google.
Okay.
Believe me. Believe me, it is messed up. A lot of doctors try their best to get their fears off, but their fear stays in them. So that's one thing because Google gives you the worst which can happen in PCOS. One in every six girls has got PCOS now. That's how it is ending up. One in five, one in every six. So it's like an epidemic.
Yes.
Anyway,
So
thank you so much, all of you. I hope
yeah,
I've done
thank you, sir.
justice to your chat show.
Yes.
And if for those people who are bored and who perhaps went out to sleep, I'm very sorry.
So,
Thank
thank
you.
you very much, Dr. Manohar, sir. It was indeed a wonderful
Same here. Same here.
conversation with you. Thank you very much, sir.
Same here. Thank you so much. Bye bye.
Thank you. Bye bye. Good night. Yeah, good night, everyone. Yeah, technical team, you can stop recording.